I'm so delighted and absolutely thrilled that to launch our faculty development webinar series, we have a guest speaker today, Dr. Lisa Richardson. And I'll let Dr. Richardson do the full introduction. But the other thing that I would like to say before we go any further is acknowledging that Queens is situated on traditional Anishinaabe and Haudenosaunee territory. And I'm fully mindful that acknowledging the land is a very simple gesture. Nonetheless, it is a stepping stone in helping us unlearn, learn, and relearn about oppression, privilege, and colonization. And also a stepping stone to help us build and strengthen our relationships and really align ourselves with the struggles against systems of oppression by taking action and also by honoring the truth. Um, and on that note, I would also like you to reflect and think about on whose land are you sitting on today, acknowledging that we're joining from different spaces and places in this session. I will not do full justice to naming and listing all the accomplishments of Dr. Lisa Richardson. Dr. Richardson is a national and international leader, and I'm absolutely thrilled and delighted and feel quite an honor to have her with us today. So Dr. Richardson, thank you so much for making the time and inviting us into this conversation.
Thank you so much. It's really an honor to be here, and thank you so much for the invitation, Claudiana, and for the all of the organization, which was outstanding, Michaela. So I just wanted to acknowledge that, and acknowledge that I'm a guest actually in the territory that I'm on in Takaranto. I am an Anishinaabe, but my territory is north of here, Anishinaabe of the Great Lakes, so south of community called Wikwemikong and Manitoulin Island. Our community is called Shebononning. So I'm currently a guest of this territory of the Mississauga of the Credit and the Haudenosaunee. And here on Wendat, we're from Wendake, we're previously in this territory. And the Seneca and many other peoples now gathered here. So, you know, acknowledging as we do when as visitors, when we're entering into territory that's not our own. And I think I love the way you did that land acknowledgement, Claudiana, because one of the things we speak about is how there is a lot of possibility for things to become tokenistic. And that if we're really, that a land acknowledgement, when people ask me about how they should engage in that, it's really not about reading something from a script. It's about, you know, referring so that you're able to understand and not forget anything, but learning to pronounce the words of the nations whose territory you're on, learning to pronounce their nations' names, learning and thinking about how you have built relationships with the people in that local territory and what your responsibility is to do that. And so it really is an act of reflection and also reflexivity of thinking about your own position and positionality. So thank you again for that. I'm going to, Claudiana had asked me to talk about creating inclusive learning environments, and I'm going to speak about it from the perspective of the work that I do in Indigenous medical education, with an understanding that the concepts that I'll be sharing around cultural safety and trauma-informed education and allyship and anti-racist practice are foundational ideas that will create safer learning environments for everyone. And that is a teaching that I've had from an elder, one of the elders I work very closely with, which is that when we uplift our systems to support the well-being of Indigenous peoples whose health outcomes have been so poor due to the structural marginalization within our system, when we create systems that support Indigenous peoples, and then these systems will uplift the well-being of all peoples, because they will create better environments overall. And I think I wanted to situate the work in that context. So although you will see that I'm speaking specifically from my situated lens as an Indigenous medical educator. These really are broader ideas. I think that's, so, you know, please feel free to ask me questions. I work closely with my colleagues in who are you know, we understand the solidarity of working across Black and Indigenous communities, that we need to be supporting one another as both having experienced the effects of colonization, but I think also recognizing the need for distinct approaches for specific groups. So that, what are those foundational ideas that you need for the learning environment for all of your learners, and then what are the specific programs, pathways, supports that you need for specific groups. So I'm trying to be a good medical educator here, so just to share a few objectives, which are to introduce and apply that during this, hopefully I'll introduce you to, and you'll think about applying the following conceptual frameworks to support the well-being of learners: cultural safety, allyship, trauma-informed care, and anti-racist practice. And then I want us to think a little bit about interventions to support change. And whenever I'm thinking about those interventions, I think about what can be done at the individual level. If we had time, we think about the institutional level, and then at the system level. So I had said to Claudiana that I would introduce myself because that is our practice. I'm a mixed blood Indigenous woman. I'm Anishinaabe on my mother's side, mixed settler on my father's side, primarily Scottish actually on his side. And I work as an internal medicine doc here in Toronto. I'm originally from Northern Ontario, though, from a couple of different places, Kirkland Lake and North Bay. My community is known as by its Western name of Killarney. We're currently under the process of trying to be recognized as our own band, because it turns out that our chief never signed on to the Robinson-Huron Treaty back in the 1800s, which is the treaty that covers most of the area. And the traditional Anishinaabe name for our territory is called Shebanoning, which is the canoe passage. So it's on the northeast part of Georgian Bay, and is now actually known primarily as a holiday and camping and canoeing place. And interestingly, because we didn't actually ever have reserve status, that land, most of that land is now owned by cottagers, and many of us actually, you know, are not able to be there because the land value is very high. So in fact, what happened, actually, there's a lot more complexity to that, but it's just, I share this story to actually explain some of the process of colonization, which I think are really important to identify. And actually, one of the things that happened when the name transitioned from Shebanoning to Killarney from back in the 1800s was when Canada Post put a post box there and actually changed the name of the village. So these, if we look at all of the different types of institutions that become representations of a colonial government, we don't often think about the post office, but that's a good example of that. And the other piece that I like to share is that we're seeing this incredible resurgence now, and that some of the young people, who are now in their sort of late 20s and are doing graduate school, and one incredible woman, Sarah Prue, is actually doing archaeologic digs on our site because she's doing her PhD in that area in our community, and actually unveiling incredible artifacts from our community, and also locating them in the ROM and in the University of Minnesota Museum, and actually using that as grounds to kind of explain that this is where we have been, our ancestors have been for hundreds and thousands of years. And so through that process of organizing these young people, we've been having community meetings around how to actually do that negotiation to become our own recognized band, so that we don't have to register with our cousins up and down the bay. But what that story illustrates is the story of resurgence. And my sister always nudges me and reminds me, we don't use the word revitalization, because our ways, our cultures, our languages actually did not die. In fact, they managed to persist despite tremendous attempts to assimilate and eradicate. But what we're seeing now is this incredible resurgence. So I also model this idea about where I am, my location, as a part of flashing forward to the idea of cultural safety. Because cultural safety is about recognizing that we are all bearers of culture and that you have to locate yourself. And last night I was lucky enough to be on a panel with some great people. And one of the things that we talked about, including Cindy Blackstock, so that was like a joy, because I'd never spoken on a panel with her before. But one of the things I talked about is how when we go into medicine and put on our white coats, we're expected to sort of erase our whole history and our whole past and all of our beliefs that come with us. And so this idea of reflexivity is actually recognizing that we do not, that those stories, those experiences, the culture that we have grown up in, and the environment, the society that we've grown up in, which has often inculcated us with a lot of negative stereotypes and biases, are carried with us into our practices. And reflexivity is about acknowledging and understanding what the implications are for that. So I'm going to, as I said, speak a little bit about, I'm going to speak primarily about the experiences of Indigenous learners. We know that our schools across Canada have been recruiting and training more Indigenous learners. And I was saying to Claudiana, what an exciting thing for me that I'm able to respond to emails for invitations to speak, to say, you know what, I'm at really one of my primary goals right now is to recognize and support the careers of the younger generation of Indigenous leaders in academic medicine. And it's amazing that there are people, we have many more than we ever did, who are able to do talks and lead curricular design, et cetera. So the attempts to recruit we still have a long way to go, but some schools have been doing this for a lot longer than others, like BC, for example, and they schools have between 1 to 2 to 15 Indigenous students every year, which is exciting. What we know, though, from the experiences of those learners is that from various studies that they have experiences of otherness. They talk about, and this is from a study that my good friend Marcia Anderson did with others at her school at the University of Manitoba. They talked about the stories of the challenges of studying medicine and the excitement at all of the learning opportunities and the importance of strength and resilience. These were semi-structured interviews with medical students across the country, Indigenous learners. But the universal experience highlighted by all of those participants was of racism within the medical school learning environment. And Marcia did this study in 2017. She was known as Marcia Anderson Dakota then. But what we know, unfortunately, from a recent report card that was done by some amazing medical students, our Indigenous Physicians Association, is unfortunately these experiences or unpleasant experiences are persisting for our learners. Even, this was only a few years ago, but they certainly are continuing. And I think it's certainly humbling to see that we have a lot of work to do. We know that trainee mistreatment is also very common. It's actually a widespread phenomenon. This is a 2016 study, but we have many other papers that are supporting this, including our graduate medical education questionnaires. And one of the things that we know is that verbal harassment is the most common form, but most of the discrimination is based on gender and race. So this is the experience of all learners is certainly one of having experiences of mistreatment. When I look at our data here at the University of Toronto, a significant amount is from patients, but also from attending physicians and from other residents and learners. And when we look at the resident study, the national resident study, the bulk of the mistreatment again was from patients, but also a significant amount of mistreatment coming from colleagues and from attending physicians. So we know that the learning environment and creating safe learning environments is key for all of our learners. But as I've tried to share with you, this becomes extremely heightened, and we have some local specific data to demonstrate this as well. It's a significantly heightened issue for Black and Indigenous learners. And then when we look at the axes of oppression, intersections of being a woman or being non-binary and being BIPOC, we know that those experiences are heightened even more. And I just posted on Twitter an unbelievable essay in Scientific American by a Black gay man psychiatry resident in the US, describing the experience of wearing a mask to try to get through, not the physical mask that we're wearing now, but the metaphorical mask that he had to put on to get through his day-to-day life during his residency training. There are many examples of racial disparities and how they play out in medical education amongst our learners. And here are just a couple. I'm not going to go into detail because I want to move through them, but certainly bias in the selection process. And Quinn Capers IV is an amazing professor and interventional cardiologist down in Ohio. He's done a ton of work in this area and actually was up presenting to us recently, showing how some of the interventions that they've included around implicit bias testing, for example, for the admissions committee, led to significant improvement in the diversity of their matriculants. So there are some interventions that one can take to try to mitigate the bias that goes into selection for things like awards, such as the Alpha Omega Alpha Society, or for your selection process. And what we know is that when you have experiences of mistreatment, there's a link between mental health disorders, burnout, suicidality, and marginalization. So I'm trying to make the point here that we really need to pay attention to this, and we need to pay particular attention to this amongst our learners who come from underrepresented groups. This is a hard study to read for me. And I think it's hard because it resonates with what I've heard from so many, and with what one continues to experience even at the faculty level, even in being in senior roles. And it was a study of actually undergraduate students in Edmonton just demonstrating this concept, this idea of what's called racial battle fatigue, which is the depletion of mental and physical resources due to the constant engagement of stress responses to cope with ongoing discrimination. So if one imagines living just in that heightened state of, like, I'm an internist, which is in that heightened cortisol state of stress, and what that does to your physical, mental, emotional, spiritual well-being. But describing that as the racial battle fatigue, which is a common phenomenon, and I think something many can relate to. So with all of that as my argument for why we need to attend to creating more inclusive environments, I want to put forward this idea that I'm calling cultural safety for learners. And cultural safety, many will know, it was developed actually as a clinical, for clinical context. Dr. Ramsden is a Maori nurse scientist and noticed that her peoples were having terrible experiences in the healthcare system, and did extensive interviews and studied and came up with this idea called cultural safety for Indigenous patients. And I'm going to talk through a little bit what that means, but I've started to adapt the idea of cultural safety in the clinical environment to cultural safety for our educational environments. And how can we apply these concepts and think about creating cultural safety for our learners? And really, as I talk about the other ideas that the other theoretical concepts like allyship, trauma-informed care, and anti-racist practice, from my perspective, the idea is to create overall this safe learning environment for our learners. So, sorry, forgot to turn my phone off. So cultural safety emerged, it actually is distinct from ideas like cultural sensitivity and cultural competence. And I really like the comparison to cultural competence, because cultural competence is, about being competent as a clinician in understanding the culture of another group. But cultural safety actually takes that further and shifts the focus from the clinician actually, or the teacher in this case, to the experience of the patient or the learner. So one could feel like you've been an incredibly thoughtful, supportive, wonderful clinician or teacher, and then someone could step outside the classroom when the learner steps outside the classroom, and a researcher could ask them how did they actually feel that interaction went, and they could say, you know, that was terrible. Like, I had a terrible experience there. So it is defined by the person who experiences the care, or in this case, the education. It's based on respectful engagement that can help patients find paths to well-being. So it is founded in an idea of respect and of supporting people through their own strengths on their own journey. One of the key ideas about cultural safety is understanding power, and understanding the inherent differentials in the inherent power differentials that exist, in particular in the healthcare system, and in the interaction between a patient and care provider. But one can see that the same thing, of course, occurs in the educational environment between a learner and a teacher, supervisor, attending physician, etc. So understanding and becoming aware of those power differentials, not just at the individual level, but at the institutional level, and how for certain groups, when you have been historically mistreated in such a severe way, such as for Indigenous, First Nations, Inuit, and Métis peoples across our country, entering into an institution is an inherently risky activity. And so there is an even more significant power differential in that context. And it requires an acknowledgement that we all are bearers of culture, as I said, so that we are reflecting on our own attitudes, beliefs, assumptions, and behaviors and values. And that is a constant activity. So we were just updating our website for our Department of Medicine. And, you know, we ask everyone to do the implicit association testing before any of our selection committees, whether it be for the CARMS residency or for a search committee, for a division head, etc. And I said, I want to add into that request that this is something that one should do not just once, but that one should do before every search. It's not a one-time, oh, you're done, you know that you have pro-white male bias, for example. It's something that one needs to continuously reflect and think about, because, you know, our positionalities do evolve, our learnings evolve, and we need to understand that this is an ongoing, lifelong learning experience. So from my perspective, culturally safe medical education, adapting the Royal College definition around culturally safe care, means that healthcare educators must take into consideration the social, political, linguistic, economic, and spiritual realm in which their learners live in order to communicate competently with him or her. So that we need to actually be thinking about our students, our learners, in those holistic ways. And we need to be understanding that they may have certain experiences based on being from a particular group. But I'm going to talk a little further about not making assumptions either. So I think a helpful lens to be thinking about the education that we're providing. The next idea is that of allyship. And we're seeing a lot of talk around allyship right now. It's great. It's exciting for me. I like Ashley Hislop's definition of it. Or this idea that it's imbued with the notion of cultivating, building, and strengthening relationships. It is about relationality and relationships between two differing individuals, groups, or communities. And coming back to, you're seeing this thread of theme of respect, as we talked about with cultural safety, respectful, meaningful, and beneficial interactions. So, you know, there's been some critique right now around this idea of performative allyship. Like, when one is stepping up as an ally to support someone who's experienced mistreatment or is from an underrepresented group, who is benefiting from that? Is the person who's stepping up as an ally benefiting because it gives them academic capital, credibility, they feel good about it? Just to really be thinking really deeply about what allyship means, I think is important. Lynn Gale's an Algonquin scholar. She's at Trent University in Indigenous Studies there. And I encourage you to read her full Ally Bill of Responsibilities because it's specific to Indigenous peoples, and you can Google it and find it in 2 seconds online. But I'm picking out 6 of the 10 that she's mentioned here. So number 3 is that allies are fully grounded in their own ancestral history and culture. So again, going back to what we spoke about with cultural safety, locating yourself, reflecting and thinking about who you are and what your own history is. And I would argue celebrating and acknowledging that too. Allies are aware of their privileges and openly discuss them. Allies reflect on and embrace their ignorance of the group's oppression and always hold this ignorance in the forefront of their minds. When you initially read that, you think, oh, but does that mean you're ignorant? The idea is that you're continuously recognizing that you do not necessarily see or understand or experience in the world in the way your First Nations colleague may. And that if you are choosing to not see that or not aware of ignoring that, then you are actually contributing to the oppression. And number 6 is are aware of and understand the larger oppressive power structures that serve to hold other groups and people down. And one way to do this is to draw parallels through critically reflecting on their own experiences with oppressive power structures. So how do you move through a particular environment? What are your experiences? So for example, when I was at a senior meeting the other day, you know, it was not a totally diverse group, I would put it that way. And we were speaking about wellness in the context of COVID, and one of the things that was brought forward by one of the leaders at the table was we just need to encourage people to come forward and be vulnerable and be open about their vulnerability. And I thought, well, that's coming from the perspective of someone in a very specific location, because I can tell you that, you know, as a mixed blood Indigenous woman who's, you know, constantly having to perform in order to not be considered, you know, less than, acknowledging vulnerability makes me extremely vulnerable and puts me at risk of actually having, you know, being constructed in a certain way. Oh, you're emotional. Oh, you can't cope. Oh, yes, of course you're like that. Of course you have all this baggage as an Indigenous person, etc. So, you know, that idea about thinking about your own experience with a particular environment and power structure, I think is important. And I like Lynn's analysis of that. So pause here to move on to the 3rd framework, and I promise you there are only 4. The 3rd one is the idea of trauma-informed care. And my colleague and good friend, Arno Kumagai, who's a medical educator, has written about trauma-informed medical education. And he actually doesn't call it that, but I would say that that's what it is. He wrote a beautiful paper called Cutting Close to the Bone in Medical Education. Trauma-informed care, again, is from the clinical context. It's about increasing the safety of care we deliver within our healthcare settings by considering the possibility that each individual we engage with may have a traumatic history that we're unaware of. And when I'm teaching this in the clinical realm, I say, you know, it's like, it needs to become like hand washing, prophylactic activity that we do for everyone. We assume that someone may have had a traumatic experience somewhere in their life or in their community's life, and that coming into the healthcare system could be a very difficult experience because of that as an institution. And for example, for Indigenous peoples, as a colonial institution that has inflicted a lot of violence in many ways. So being aware that people may have experienced it, not asking them about it, but recognizing that you have to behave in particular ways, introducing yourself, identifying people who you are, what your role is, what tests they may be going for, why you're doing the things that you're doing, alerting them to the fact that you may be putting your hand on someone to examine them, etc. Trauma-informed providers acknowledge the widespread impacts. They recognize the signs and symptoms, understand that people may have a variety of creative means to manage trauma, such as anger, avoidance, substance use, and recognize that people follow different pathways to healing. And a trauma-informed institution, an educational institution or a healthcare institution, needs to integrate knowledge about this into their policies and procedures. So how can we actually start to think about after I've described and given a little bit of context around the experience that our learners have in our medical institutions, how can we actually respond to that by thinking that these educational institutions, for example, for Indigenous peoples, based on the residential school experience, have been experiences of colonial violence and trauma, and how can we change the way we practice or set up our academic and medical environments to be trauma informed. The trauma toolkit, by the way, is online and it's excellent, and these are some of the important principles. So making people feel safe, having them trust you. So if you have a racist experience as a learner, feeling that you will be trusted but if you explain this to a supervisor, and that you won't have to justify it, that you will have choice and control over whether you report that you would be treated with compassion and care and respect and love, that you will collaboratively decide on a way forward, and that whatever is determined around the way forward, for example, going back to the complaint around racism, that you are allowed to be a strong person and not considered a victim, so that it be a strengths-based approach. And to take the idea of trauma-informed care even further, Maria Yellowhorse-Braveheart, who's an incredible Lakota psychologist and PhD, who wrote about the concept of historical trauma for Indigenous peoples, and looked at this idea of how historical trauma leads to collective suffering and memory. And for her, she studied her own people, the Lakota, over the course of, and looked at the colonial experience and attempts at assimilation. And she talks about the idea that this historical trauma is collective. So although one may not have individually experienced trauma, so maybe you were not a residential school survivor, but your grandfather or your mother may have been, or your grandfather. And how does that become collectively a part of your experience that may affect your experience of an educational institution? And she actually wrote further about it and described this whole historical trauma response. And whenever I'm speaking about historical trauma, I acknowledge that we actually learned this. Maria Yellowhorse-Braveheart learned about this from Holocaust scholars. So this is a well-known and well-developed phenomenon amongst survivors and survivors of the Holocaust. And so I always like to acknowledge that that's the origin of this idea. So a few cautions about the concept of historical trauma. It's not culturally safe to assume that everyone within a particular group or communities or family has been impacted by it. So this is where it's complex, because one has to be aware that, oh, you are from this particular community, this First Nations community, and I know there was a residential school right there, so maybe your family, maybe there is a residential school history or 60 scoop or child welfare in your family, but I don't want to assume that you've had that. But a trauma-informed perspective would say, keep that at the back of your mind, that could be impacting your experience of this learning environment right now. Historical trauma has been stigmatizing. It can be used to stigmatize particular parenting practices and overlooking strength and resilience and persistence. So just a few cautions. I find it to be a really helpful concept, but I wanted to issue those nuances around how we think about it. And lastly, this concept of anti-racist practice, and I'm gonna grab it because it's right here, doing a little show and tell. I really, really love this textbook, and I have it in my slides at the end. It's Josephine Otoa and Elizabeth McGibbon, and everybody right now should be reading this book in the context of our healthcare and education practice, anti-racist healthcare practice. It's very practical, but it's theoretically grounded, but practical. So really getting that praxis idea of theory in practice. And I highly, highly recommend it. But I also like to share this idea from Dr. Chelsea Bond, who's an Indigenous educator, health educator in Australia, who interviewed a bunch of health education leaders in Australia about including content related to racism in the healthcare system. And you know, she got a lot of feedback back suggesting that people did not think it was relevant. And so she writes this quote about how might we get to a position which recognizes that to teach about race is not racist, but rather that pretending race doesn't really structure health outcomes is. So I think what's happened in the last 6 months or in the last 4 months is I have seen a recognition that we need to talk about racism. We need to talk about it in our institutions, our health institutions, our educational institutions. We need to no longer say it's not happening where everyone's treated fairly and equally. We need to see that it is happening on a day-to-day basis. And I just shared with you about the experiences of medical students. And we need to actively dismantle it and address it. And so McGibbon and Otoa talk about the 3 primary processes for doing that. Number 1 is that awakening. I've seen seeing how stereotypes start to play out and seeing that path from a stereotype or idea that comes into your mind and how it leads to an oppressive practice. So how it might affect the way you treat a patient, for example. So if you have a stereotype of a certain person of a certain group being more likely to be a drug user, for example, what does that mean in terms of the way you may treat them? Or what does it mean in terms of your understanding of a learner? If it's an Indigenous learner, do you have a particular stereotype? Oh, they probably only got here through this path, and does that affect the way you're then interacting and treating them? Then we need to understand that those particular practices that play out in the individual level actually affect structures and policy. And lastly, we need to act. So this is not just about, as I have routinely told the chair of our department, who I get along with very well, we're doing way more than just our statement against racism and violence. Like, we need to have the action to actually make change in our representation, in our who has power within our department, and in who has resources to do that. And before starting, Claudiana and I were talking about an incredible commentary that came out in the New England Journal yesterday about anti-racism in academic medicine. And they do talk about those 3 ideas that I've just mentioned. So representation, increasing representation of Black leaders. This was specifically had a Black focus. Ensuring that people who you're recruiting actually move into positions of power as well. So Claudiana and I were talking about this sense that you shouldn't just be in an equity portfolio. I mean, I love doing Indigenous health education and it suits me very well. But if I wanted to be considered to be the chair of neurosurgery because I was a neurosurgeon, there would be a recognition that having different perspectives and different background actually strengthens and brings excellence to my portfolio, no matter what it might be. And that, so representation, power, and of course we know in any context, capital, as in financial capital and resources, support power. So number 3 in their recommendations from that commentary yesterday is that there be a transfer of wealth and resources within the institution to allow the self-determined, I'm going to use an Indigenous phrase, self-determined enactment of change meaningfully. So moving into the last section, I wanted to share 2 scenarios, and I'd encourage you to, there's an opportunity now for you to ask questions or reflect on how you would work through these scenarios. Again, if nobody wants to talk, that's fine. I know that people are probably having lunch and this is a lot to absorb, but I would love to hear how people might work through these scenarios, and hoping that these ideas that I've spoken about around stepping up to be an ally, cultural safety, being informed by trauma, and acting in an anti-racist way might help you work through them. So, sorry. I'm gonna, before I go through this, I want to be trauma informed actually as an educator, and I want to let people know that these are two significant issues that occur. These are not based on particular real life experiences that I know of, although I hear about these sorts of things all the time. And to recognize that for people who've experienced mistreatment or discrimination in their learning environment or in their clinical or working environment, these could be difficult. So this is a little a heads up around the content. It is difficult to talk through. You're an education lead on a clinical rotation, and you're doing your debrief with your resident, with one of the residents at the end who's First Nations, and shares the following experience. She was asked to assess it's a cardiology rotation. She was asked to assess a patient with chest pain in the ER. The patient was First Nations and visibly so. The resident diagnosed him with a non-ST elevation MI. She phoned her attending physician, proposed that the patient be taken for cardiac catheterization. After learning the story, the attending physician stated that it was not a good idea to perform angiography since the patient would not be compliant with antiplatelet therapy and other medications because as a First Nations person, he likely has problems with substance abuse. So I'd love for people, if anyone has any thoughts, think through this for a moment about how you might approach this. Feel free to share, either raise your hand and Michaela will make sure that you're able to be unmuted. Just unmute yourself, or you can put things in the chat too. Claudiana, I'm not seeing the chat because I've got my screen on, so I don't know if you could let me know if there's anything that comes up in the chat.
Absolutely. I can monitor. Lisa, as people think through, can I ask about something related to cultural safety and its cultural humility, and how do you see the two related?
Yeah, so I mean, there's a really beautiful piece that Northern Health has done in BC around that spectrum. So cultural humility is about is bringing that humility around your own location, and the fact that you don't you do not understand the cultures and experiences of others into every interaction. And it's that humility that actually enables you to create a culturally safe environment. So I actually see them as being tied together very much.
Okay. That's great. Thank you for that. I see some comments coming in.
Okay. Do you want to read them out, Claudiana?
And I can sense to defer treatment for a patient just because of his background and race is just wrong.
So I'm gonna address. I mean, this. Thank you for that. Definitely egregiously wrong for so many reasons. We know that this happens all the time for Indigenous peoples, and and more of a huge literature in the U.S. around the experiences of Black patients as well. So this is I have about 2 conversations a week from different community members who are concerned about the treatment that they've had in healthcare institutions. So this is quite common. I think if we were to think about those concepts around the learner's experience, because let's think about how we can support the learner going through this. So when she has seen a member of her group, I don't know if they're from the same nation or community, but when she has seen someone do that actually can be very traumatic, because to witness racism in that direct way can be very traumatic and startling and upsetting. So I think number 1 is to be trauma informed and to understand the impact that racism has, even if you're not directly experiencing it. When someone from your community, your group, is experiencing it, that could be deeply upsetting. And remember, we don't want to assume what this resident may experience, but to understand that this could be a very traumatic event, and that we need to support her well-being in order to create safety for her, number one. So number two, if you were to step up as an ally, you would have that awareness and understanding. But allies actually, and we didn't go into the nuances of how to act, allies act with and not for. So allies should always be acting based on what the person who's experienced the mistreatment would want. So in this case, if the resident is feeling, upset, traumatized by what happened, as an ally, how do you support her? Saying you listen, understand, hear. The worst thing one can do is say, I'm sure they didn't mean that, right? There are all sorts of responses that would actually totally negate her experience, and then work with her around what she would like you to do to intervene. So would she like you to file a complaint? Would she like to just keep this quiet, etc.? So that's at the individual level. But then if we think about anti-racist practice and acting, is there a way that one can act to actually deal with this with this problem at an institutional level? So can one start to look at creating structures for reporting these experiences of mistreatment that patients may have or that may be witnessed by other care providers, and acting on them at that institutional level? So thinking about those different ways in which one can support the learner at the individual level, be aware that this is created an unsafe environment for her to witness racism in this way, and that she must be supported, that she will determine what that support looks like, and that you, in the meantime, in acting as an anti-racist way, are working to think about how to change the institution where this is happening.
And Lisa, just to say that there were some comments along the same lines as you were speaking. So the patient has been stereotyped and discriminated against, and the resident is Indigenous, so he's being doubly exposed to that same racism. And again, knowing how to address this biases that we all have, and to witness how much your attending supervisor hates and discriminates against your own peoples, that would lead you to perhaps hide your own identity and be able to continue working with that physician.
Thank you so much for that comment around hiding the identity, because really when we think about inclusion, not just diversity, but inclusion allows everyone to be themselves and feel respected and supported to be themselves. So not having to put on the mask based on the essay that I just referred to in Scientific American written by the trainee in psychiatry, but that you can be yourself and be respected in that way. So a really important part of a culturally safe environment, learning environment, is you don't have to hide your indigeneity or your, queer identity or your other acts, other intersections that may make you in the non-dominant group. I have one more scenario, and then we'll talk a little bit about individual and structural change. So you're a program director in a large residency program. You received an email from the wellness lead regarding concerns that were brought forward by 3 residents over the last few months. They describe hearing offensive comments related about women. Sorry, I adjusted this at the last minute, so some typos, and the CARMS pathway for Black and Indigenous learners, so a special pathway that's been supported to recruit Indigenous and Black residents into your program. Comments were made by other residents and occurred in the setting of the academic half day, and most of the comments were made with a, quote, joking tone. So I'm going to I'm going to talk through it in the interest of time because we only have 6 minutes left. But I think, again, thinking about creating the culturally safe learning environment. When residents are witnessing or experiencing this, whether it's directed at them specifically or at a group with which they identify or at a group with which they feel allyship or kinship in some way, this is an unsafe environment. And so as a leader in the program, you have a responsibility to act on that. And so there are many different ways in which one might think about acting, but again, coming back to allyship, that you are an ally with the residents who have experienced, who have concerns about what they've witnessed, and residents against whom this may have been addressed, such as Black and Indigenous learners in your program, and that you are committed to acting to change it in an anti-racist way, so that making, not just seeing that how the stereotyping has led to this mistreatment, but actually how can you going forward create environments where this is not happening, so that proactive creating a culture of inclusion, which includes also being able to deal with these incidents of racism as there, or mistreatment or discrimination as they occur. I always talk about the two. We're always looking forward and trying to, and strengths-based, creating an environment which is of a positive, the positive framing of what a professional working environment looks like. But the caveat is that you still do have to have the, negative, the approach to deal with the negative behaviors, so that you're looking at both in any context. I think this idea about the joking tone is another example of racist or dismissive, a common racist approach, where it's either diminishing what someone has said, I'm sure they didn't mean it, or I'm sure it was just a joke. So this kind of behavior is clearly not a joke and has to be taken seriously. I think when you're thinking about interventions to deal with this, I'd like you to think both at the individual level and at the institutional and system level. So at the individual level, I ground wellness in an Anishinaabe idea for directions of health, so mental, emotional, physical, and spiritual. So for, likely not, if there may be, if let's say, take the example of the resident in cardiology, a physical response might be, is she safe to continue working with that clinician? Does she need to actually be physically removed from that learning environment? A mental response is, what supports might she need? Who can I connect her with in our resident wellness office, for example, to support her? An emotional response would be around thinking about her relationships with leaders, with educational leaders in the program. How do you build those strong relationships that will create a supportive environment for her? And the spiritual, we talk about spiritual well-being as Indigenous peoples, not about in the religious sense, but about really supporting the well-being of the spirit. So when you've witnessed racism like that, Diane Longboat, an elder I work with, talks about the soul wound that creates, and how one has to understand the intensity of that sort of a witness behavior. And then if we think about the system level interventions, thinking preventatively, as I was saying before, the positive and then the response or the treatment. So who are in your leadership roles? Do you have an equity and inclusion plan, strategic plan? Do you have an Indigenous health workforce plan? Do you have an active education plan for all of the physicians and other healthcare providers in your institution? Do you have a way to support the well-being of your faculty and of your learners, like an officer of wellness? And are you actively keeping track and researching what's happening within your institution? And when these issues occur, both of these examples, do you have a person or an office in a leadership role to actually be able to, one, support the well-being of the learner, but two, debrief and investigate that, quote, complaint? Is there a way for safe reporting, anonymous reporting, and data in aggregate to be shared with communities? Do you have specific interventions to deal with that clinician's bad behavior? Do you have coaches? Do you have, in egregious cases, there will need to be professionalism repercussions, possibly with the College of Physicians and Surgeons, et cetera. And are you keeping track of the data? So Claudiana, with 1 minute left, I'm just going to share some helpful resources. The online cultural safety module, which is just incredible. My friend, Dr. Allison Crawford, who I do a lot of work with, is a white physician who has with Inuit children and spends a lot of her time in Nunavut. So she did this website called Inuit Story Bones about trauma-informed and cultural safety in an Inuit context. We wrote a joint commitment to action in Indigenous health for the AFMC, our Indigenous Health Network. The anti-racist textbook, which I talked about. I use Unpacking the Invisible Backpack a lot. We use the implicit association test. We've written a really great primer that's been getting incredible reviews from people for the Royal College. So when you're looking at your educational strategies, it's a free online book. Lynn Gale's Ally Bill of Rights, the TRC UNDRIP, and the Manitoba Trauma Toolkit. So 1 o'clock. Not much time for questions, but we have a little interactivity along the way. So Claudiane, I'll leave it to you if you want to have time for one question, or just cut us off.
If you're okay with that, we can take one question if there is a burning question, but I do realize that it is 1 o'clock. And I do want to thank you formally, because I can speak more for myself when I say this, and I hope it resonates with others here today, how you have unsettled us and invited us to examine our ways of thinking and our ways of practicing, and did so in a culturally safe environment. But in addition to that, not just the conversation, you've given us a sort of a toolkit. You're talking about the trauma-informed toolkit, but all of this is strategies and resources that we can use, and use them well to continue to take action and continue to dismantle all different forms of racism and oppression. So thank you so very much.